Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Ioannis Stavrakakis from Crete, Greece. Dr. Stavrakakis obtained a CCD in orthopedics and trauma after completing his Greek national examinations in 2014. Later, he qualified for the FEBOT in Vienna and also completed fellowships in Glasgow, UK, and subsequently obtained his Master of Science from the University of Crete in Greece. He later traveled for the EFES traveling fellowships. He has published in several leading orthopedic journals and is also a reviewer for some of them. So today is my great honor to introduce you to Dr. Ioannis Stavrakakis from Crete, Greece. Over to you, Ioannis.
Hello, everyone. It's an honor to be here participating in Professor Gopalan's Orthopedic Principles. I'm glad to share with you my presentation regarding Lisfranc injuries. So yeah, I'm currently working in Greece, in the southest part of it, which is an island called Crete, and that's the hospital I'm working currently. Lisfranc, the name of the injury is attributed to a French surgeon and gynecologist who lived in the Napoleonic era, and he was the first to describe the injury in 1815, and he also described an amputation at the same level. Regarding bony anatomy of the tarsometatarsal complex, the three cuneiforms, they have a trapezoidal shape, forming a nest where the second metatarsal lies, and this structure increases the stability of the midfoot. The second metatarsal base and its articulation to the cuneiforms represents the keystone of a Roman arc of the midfoot. Regarding ligaments, the Lisfranc ligamentous complex consists of the dorsal ligament, the interosseous ligament, and the plantar ligament. The interosseous ligament is the thickest component, and it has the largest insertional area on the second metatarsal base. And biomechanically, the interosseous Lisfranc ligament has the greatest stiffness and resistance to load before failure. This is an image of the neurovascular anatomy of the midfoot. When performing a surgery around the midfoot area, one should keep in mind that the neurovascular bundle lies just laterally to the extensor hallucis longus tendon, and it is underneath the muscle belly of the extensor hallucis brevis muscle. Regarding epidemiology, Lisfranc injuries represents 0.2% of all fractures, though I think that this number may underestimate the true incidence of the injury, because many subtle injuries are missed on the initial examination. Men are 2 to 4 times more likely to suffer from the injury. It is common in young people, and the majority of it are closed injuries, and are becoming more and more frequent in athletes. Regarding the mechanism of injury, this fracture dislocation of the Lisfranc complex may result by either a direct force, either a heavy object falling onto the dorsum of the foot, or a vehicle accident, or an indirect force, which is the most common mechanism of injury, and it occurs over a rotation of the forefoot while the foot is in plantar flexion, and this forces the TMT joint. A clinical image, the patient may or may not be able to bear weight. There is obvious midfoot pain. On inspection, there is swelling and plantar ecchymosis, as you can see on the image on the right side of the screen. But you have to keep in mind that this sign might be visible a few days later and not on the initial presentation of the patient to the accident and emergency department. On palpation, there is midfoot tenderness. The forefoot, twisting the forefoot reproduces pain. The patient may not be able to raise his heel. Always look for a compartment syndrome and check for dorsalis pedis artery pulse. Imaging, plain X-rays are of paramount importance. Anteroposterior view, oblique view, and true lateral view. If there is a static injury, it will be visible on the X-rays. Then, if you're unsure about the diagnosis, you should proceed to a CT scan, which also aids to your preoperative planning. If there is uncertainty regarding the diagnosis, whether it's a stable injury or not, then it is very important to perform bilateral weight-bearing X-rays in order to identify any subtle cases. Weight-bearing CT scan is a very useful tool if it is available in your hospital. In my hospital, unfortunately, we don't have it, and I think it's still very rarely used in other hospitals too. MRI scan, I put a question mark here. I don't think it's necessary in order to diagnose the injury and in order to distinguish between stable and unstable injuries. I only perform MRI scan in stable injuries just to confirm my diagnosis, and that's how I know for how long I'm going to immobilize the foot. Regarding classifications, there are many classifications described in the literature, but the Meyerson classification is the most widely accepted, and it consists of the type A, which is a homolateral injury, and the forefoot displaces either medially or laterally. Type B, it represents a partial incongruity of the joint, which might affect either the medial column or the middle column or the middle and the lateral column too. Type C is the divergent type, where the medial and the lateral and the medial and the middle or middle and lateral columns are separated. Sorry. The non-linear Fertullo classification is mainly used for subtle injuries. It consists of the grade 1, which is a sprain of the ligament, grade 2, where there is a partial disruption of the ligament and there is a diastasis between the first and second metatarsal around 2 to 5 millimeters, and grade 3, when the diastasis is more than 5 millimeters and represents a complete disruption of the ligamentous complex. That's a very good algorithm of managing these injuries. So when there is a suspicion of a Lisfranc injury, perform plain X-rays, look for a plantar ecchymosis. If there is any doubt of diagnosis, make a weight-bearing bilateral X-rays, or if you can, stress X-rays. If the injury is stable and there is no widening between the first and second metatarsal, then you can proceed to a conservative treatment, meaning a boot cast for 6 weeks, non-weight bearing, followed by another 4 weeks of a walking boot. This is the type of injury where I use the MRI scan just to confirm the diagnosis. When there is instability, meaning widening of the M1, M2 distance, this requires operative treatment, which is either open reduction internal fixation or primary fusion. This is a case where you can see on the bilateral weight-bearing X-rays the widening between the first and second metatarsal bases on the right foot as opposed to the left one, indicating an unstable injury. That's other cases where the CT scan images aid for diagnosis and for your preoperative planning, because you are able to identify the unstable raise of the midfoot. Regarding treatment, these are the questions which I will try to answer based on the current literature. First question is fix or fuse. Second question, transarticular screws or bridging plate. Should someone remove routinely the implants? And is there any place for percutaneous screw fixation? For the first question, that's a systematic review published in 2016 in the Clinical Orthopedic Related Research by Dr. Smith, where the authors concluded that there are no significant differences in terms of functional results or in terms of non-anatomical reduction when comparing primary fusion versus open reduction internal fixation. And there were only significant differences in the reoperation rate for hardware removal when ORIF was used. That's another retrospective case series studies where the authors also concluded that excluding planned removal of hardware, patients with Lisfranc injuries treated with ORIF did not demonstrate a higher rate of reoperation compared with those undergoing primary arthrodesis. On the other hand, there is a more recent systematic review which includes 20 studies, and actually there is mention that the functional outcomes of primary fusion is better than open reduction internal fixation, and this difference was found to be statistically significant, but maybe it's not clinically relevant because the mean difference between the two groups was 7.41 out to 100 units. So although statistically significant, maybe this difference is not clinically important. The second question is screws or plates. That's another major debate regarding Lisfranc injuries. This is a retrospective case series studies where the authors concluded that bridge plate fixation gives a better functional outcome and quality of reduction than transarticular screw fixation or a combination of the two techniques. In this biomechanical study, it is also mentioned that the screws and the plates, they have similar ability to reduce the joint and similar ability to resist displacement with weight-bearing load. On another biomechanical comparison, the screws were slightly better than plates in terms of resisting weight-bearing load. That's a great systematic review where the functional outcomes between plates and transarticular screws are compared. And this review resulted that the AOFA score favors bridge plating as opposed to transarticular screw. And this result was statistically significant, but again, the difference may not be clinically important because the mean difference was around 7 units. The same conclusion was for regarding post-traumatic arthritis, osteoarthritis, which it favors the bridge plating group, but again, the odds ratio is too low, statistically significant though. Should someone remove the implants in a routine basis? This is a systematic review regarding this topic, published in Foot and Ankle Orthopedics in 2022, where you can see on the left side the box plot where the AOFA score is approximately the same for metalwork retention and metalwork removal groups. So the authors concluded that this study demonstrates similar functional outcomes comparing routine removal of metalwork versus planned retention following fixation of a Lisfranc injury. What about percutaneous fixation? And this is a systematic review that me and my team, we have published in 2019, gathering studies, mainly retrospective case series studies with no control group regarding this topic. And we concluded that this method is effective, safe, and relatively simple. It can give good results, especially for Mersenne type B injuries, provided that an anatomical reduction has been achieved. I will present now a few of my cases showing my current practice. So before I start the operation, I always perform stress fluoroscopic views in order to identify the unstable rays of the midfoot. As you can see on the left side, all rays are displaced when I'm stressing the joint. If I identify gross instability of the first ray, then I tend to fuse the first TMT joint using a 4.0 millimeter partial threaded screw and neutralize it with a plate. Before I do that, though, I first put the home run screw because sometimes if you first fix the first TMT ray or fuse it, and if you don't achieve an anatomical reduction, this might affect the reduction of the second metatarsal base too. And that is why I prefer to first put the home run screw, reduce the joint and put the home run screw, and then I proceed to fusing the first ray, and then I put a bridge plating on the second and third TMT joints. This is a method which has been published in the literature by Boffel and his team in 2014. So if the first TMT joint is stable, so when I'm doing my stress fluoroscopic view, I don't see any medial opening on the first ray, which is, I must admit, is rare. Then again, I first I reduce the joint, I put my home run screw, I apply the bridge plate on the second and third TMT joint, and then for the first ray, for safety, I put a Kirchner wire, which I remove in 6 weeks' time. Regarding the post-operative protocol, I keep a splint, a posterior splint, and no weight bearing for 6 weeks, followed by moon boot and partial weight bearing for another 4 weeks. If I'm not sure about the stability of the tarsometatarsal complex, I always do a bilateral fluoroscopic views and compare the two legs in order to find any instability joint, any unstable joint, such as in this case here. Always be aware for concomitant Lisfranc injury in case of lesser metatarsal fractures. You can see in this case here on the left side on the non-weight bearing view that there is a fracture of the proximal diaphysis of the second metatarsal, maybe an intra-articular fracture on the base of the third metatarsal. These fractures were confirmed on the CT scan. Again, a static CT scan, but no examination, no static imaging can show you that the Lisfranc complex is participates also in the injury and it is unstable. And this was identified just before the operation and under fluoroscopic stress fuse. So in this case, not only the fractures were fixed, but bridging plates were also applied along with a home run screw. And that's the post-operative x-rays. That's another more complex case affecting all rays of the foot, of the midfoot. And in this case, the first, a typical open reduction and internal fixation was performed. That's another case, and again, proximal metaphyseal fractures of the second, third, and fourth metatarsal. You can see on the left side, which is a weight-bearing bilateral view, that there is a slight medial opening on the first ray, indicating an unstable Lisfranc injury. This was confirmed on the fluoroscopic preoperative views, and this is the result. The first ray was fused using a screw and a neutralizing plate, a home run screw, of course. The fourth metatarsal fracture, which was comminuted, was first fixed with a plate, and then a Kirchner wire was applied to stabilize the metatarsal to the cuboid. Oh, sorry. Regarding the timing of the operation, all the previous cases I showed, I never perform an open reduction internal fixation in an acute basis. I always wait for the soft tissue swelling to subside. This takes approximately 10 to 15 days. And if there is any gross dislocation, then I perform a closed reduction, key wire pinning, plus or minus an external fixation. Then I wait for the soft tissue compromise to subside, and then I proceed to the to my definitive fixation, open reduction, internal fixation. This is an example of such an injury. Actually, this is more of a Hopart fracture dislocation. There was a huge edema of the foot, no compartment syndrome though. You can see the gross dislocation of the Hopart joint. The scaphoid was reduced and stabilized with Kirchner wires initially, and an external fixation was also applied, extending from the calcaneus to the first and fifth metatarsal base. And that's the first image. That's the result of the first operation. And as soon as the soft tissue swelling subsided, we proceeded to the definitive treatment, open reduction, internal fixation. Again, a home run screw and another screw, reducing and fixing the navicular tuberosity fracture. Cuboid bone was comminuted, non-reconstructable, and in these cases, a spanning plate is a good option, but obviously this has to be removed 4 to 6 months later, otherwise it will break. Yes, that's me. That's a cave in a mountain in Crete, where it is believed that Zeus was born and raised there. Thank you very much. Thanks very much, Professor Gopalant, and thanks for the honor you did me.
Thank you, Ioannis. Ioannis, you can stop sharing. Yeah, thank you, Ioannis, for this detailed presentation and good number of cases and good fixation as well.
Thank you very much.
Ioannis, take a short Q&A. Now, Ioannis, there is an interest in flexible fixation, right? Some people are doing a tightrope, using a tightrope to fix a Lisfranc. So where do you place that? Do you think there's a role for that? Because that needs a lot of stability, isn't it? And a tightrope wouldn't provide that.
Yeah. Many people use that. I don't believe that the tightrope provides a stable fixation. I never use the tightrope. Though it is a dynamic fixation, but I don't think I can get the stability I want for Lisfranc injuries. Okay? I'm not a fan of it.
And what about ligamentous Lisfranc? How do you approach a ligamentous?
So for purely ligamentous injuries, I prefer to fuse the first ray and then fix the second and third tarsometatarsal joint. I think it's a good solution. There is evidence of the results of it. And my experience, based on my experience, you can achieve good results with this, with partial fusion type of fixation.
And what about implant removal? Do you remove your implants? Of course, you said that the plate needs to come out, right?
Okay. Yeah.
The side plate. What about the other plates?
So I don't regularly remove plates unless there are problems with implants, broken implants or pain or something like that. I tend though to remove transarticular screws. So if I have put any transarticular screw without doing a fusion, then I routinely remove them approximately 6 months post-operation. But plates, no, I don't routinely remove the plates.
And fusion in your hands.
Sorry?
Fusion. What are the injuries where you primary fusion?
What I'm doing when I'm doing a primary fusion?
Yeah. When do you do?
When I'm doing primary fusion, I never remove the implants. There is no need to.
Exactly.
Unless the fusion is not healed. If it's not healed, unless there is pain. If there is pain, this means probably that the fusion is not healed. So in this case, probably I need to do it again. Yes,
Thank you, Ioannis.
it is an injury with
Ioannis, I
too
think
many debates. Too many debates.
Yeah.
I think we know little for this injury. There is there is a way that we need to run still.
Thank you, Ioannis. Ioannis, I think that's all the questions that we have for the session. Thank you for this wonderful presentation.
Thank you too, Professor Gubalan.
Bye-bye.
Bye.